We're going to talk about the kidneys today, so hang with me. We'll get started. Alrighty. Like I said, we're going to talk about the kidneys. I'm going to start with reabsorption today. So we're going to talk a little bit about how solutes in water are reabsorbed in the kidney tubules. And then we'll talk about some of we're going to talk about the filtration process and what goes into that. We'll talk about the RAS system, and then we'll be done. There's a lot to this, so don't feel bad if you don't understand right away, but we'll jump in. Okay, so I've got this simplistic drawing here. Okay, and this is a kidney's nephron. So it's the place where our capillaries are formed, and so this is where solutes are filtered out of our blood, metabolites, things like that, and they're put into the kidney. And then depending on if we need to keep them or not, they get either reabsorbed into the blood from the tubule, or they just keep going through and then they come out as urine. Okay, so it all kind of starts here in this. It's called the glomerulus. Wow. This is a whole bunch of capillaries inside here. It's a capillary bed. And inside of this, which is called Bowman's capsule. Okay. And then it goes here to the proximal convoluted tubule, PCT. That proximal convoluted tubule turns into the proximal straight tubule. And then it starts down here. This is the descending loop of Henle, DLOH. It goes through the loop of Henle, comes back up here. This is the ascending loop of Henle, and now we're in the distal convoluted tubule. Okay, this MD is the macula densa. We'll talk a little bit about that. It's pretty important. And then it's coming down here into the collecting duct, and we have these kinds of cells, principal cells. And then I probably won't talk about these, but I just have them drawn on. So yeah, we're going to talk a little bit about each type of these cells, what they're doing, how they're helping in reabsorption or secretion. So starting with the PCT, proximal convoluted tubule, there's a lot going on in here, right? And it's the one just right after Bowman's capsule. So coming straight out of the glomerulus, wow, that's hard to say. It's immediately into the proximal convoluted tubule, okay? Now, what's happening in here, in these cells, is we have a lot of things that are filtered out that we want to keep. So we're going to reabsorb them and put them from in here, the lumen. This is where they've been filtered into. We're going to take them from here and put them straight back into the blood, okay? So sodium and glucose, they're a secondary active transport. They're a symport. So sodium and glucose come in together through a channel called the SGLT2 channel. Okay, and then glucose, it's going to come out here, and it's going to go through a GLUT2 transporter, and then that deposits glucose back into the bloodstream. We want to keep glucose, right? That's our main source of energy. So that would be really bad if we were getting rid of it, okay? So keep that in mind. Another thing that is reabsorbed is sodium and amino acids. Same deal. Symport, secondary active transport, comes in, and then for both of these, sodium and lactate and sodium and amino acids, and then they come over here. Where did I put it? Oh, right here. They are then transported back into the blood, amino acids and or lactate, by doing antiport with sodium from the blood. So it's putting sodium back into the cell. Okay, and all of this is being driven, of course, by our sodium-potassium ATPase pump. So we're kicking out 3 sodiums in exchange for 2 potassiums inside. This is what's driving all of these mechanisms, right? We're kicking out these sodiums, so we need to bring them all in. All of these things are happening, right? So this is the main driver for our transportation and stuff. Next, we have these aquaporins. We are going to reabsorb about 70% of our water in the PCT, the proximal convoluted tubule. Okay, so these are wide open. H2O is coming in, going back into the blood because we don't want to get rid of all of our water. We also have sodium coming in and hydrogen ions coming out. When these hydrogen ions come out, they combine with bicarbonate in the lumen that was filtered, and then they react with carbonic anhydrase. Carbonic anhydrase changes it into carbon dioxide and water, and then that is able to diffuse across the membrane. Carbonic anhydrase then causes these to then go shift back to hydrogen and bicarb. The hydrogen ion is then recycled to keep going there, and the bicarb is kicked out into the bloodstream with sodium. So those are a symport. Okay, and then of course we have our potassium leak channel that's allowing potassium to get back into the cell. There are a few other things, but these are the main things that I want to focus on in my lesson today. And the blood that it's being reabsorbed into is formed by our peritubular capillaries. Okay, so what happens here, I'm just going to do this really quick. We have an afferent arteriole that comes in. It turns into the glomerulus. That's a capillary bed. And then it comes back out as the efferent arteriole. And then what we do is we have all of these peritubular capillaries just kind of wrapped all around this. And it happens over here too. Okay. And so as this is coming, it follows all of this right here, right? That's why I have it drawn this way. But what it's doing is it's moving kind of opposite, and that'll be important in a little while. The blood is moving in the opposite direction that the filtrate is moving. Filtrate's moving this way, blood's moving this way. Okay, keep that in mind. Then we get over to our proximal straight tubule. Okay, now a lot less is happening in here, thank goodness, right? So what we have here is a sodium being pumped in and a hydrogen ion being pumped out. We also have a chlorine being pumped in and an anion being pumped out. Just some negatively charged particle, right? So then our anion and our hydrogen ion, they combine out here and they diffuse across the membrane. And once they're back inside the cell, they split up and the process starts over. So now we're getting sodium and chloride into the cell. We have, again, our sodium-potassium ATPase pump. So then we have chloride leak channels, potassium leak channels, and then we also have this transporter that's kicking out both potassium and chloride together. So that's how that's working. And this is helping us reabsorb our chloride ions. That's important. We don't want to lose those. So we've just reabsorbed glucose. We're reabsorbing sodium like crazy, amino acids and lactate, bicarb, and potassium. Okay? And now we're also reabsorbing chlorine, adding to that mix. Now, we reached I didn't draw this one out. This one's really simple. In our descending loop of Henle, we only have aquaporins. We have a sodium potassium ATPase pump working as well, okay? But the only thing that's happening is water is being reabsorbed. But remember, the majority of water is reabsorbed in our proximal convoluted tubule. But a lot of water is reabsorbed here in our descending loop of Henle, okay? And that's all we have. No ions are leaving, only water here in this area, okay? Then on this opposite side, right about here, it switches. And now no water can get through, only ions are getting back out into the blood. That's going to be important. So in the ascending loop of Henle, we have what's called the NKCC2 channel. We're getting a sodium in, a potassium in, and 2 chlorides. This transporter is a big deal. It's helping us pump out a ton of ions. So we're getting sodium out, potassium out, chloride out, and we're getting bicarb out. We also have this leak channel on this other side, kicking out some of our potassium. And we also have this sodium hydrogen antiporter that's happening. We have the carbonic anhydrase working down here as well to help bring some chlorine in here. But we just kick it right back out. Okay, so in the ascending loop of Henle, no water is coming through. There are no aquaporins, but we are putting out a ton of solutes. Okay, so that's all increasing. A bunch of ions, things like that. All right, then we get to our DCT, our distal convoluted tubule, and the special cells that are in there are the macula densa. The macula densa is really important in sensing how much sodium and chloride ions there are by the time it reaches the distal convoluted tubule. And depending on how much there is, it'll cause a release of renin, which we'll talk about in our RAS system. Okay, so I'm not going to go into it right now because we're going to get there later. But this is really important. We're going to talk about it. And this is a NCC channel right here. And again, it's just kicking out more ions into the blood, more solutes. Got our sodium, potassium, ATPase running things. And then we get to our principal cells. And these guys, they're like at the very end of the distal convoluted tubule, very beginning of the collecting duct. Okay, so they're right in this area. Now, what's happening here is we have this channel called an ENaC channel, which is just letting sodium come in. Okay, and then we have our sodium, potassium, ATPase pump coming. We're going to talk about what aldosterone does and what ADH does in a little bit. I don't want to do it now, but I have it drawn on so that when I do talk about it, I can just come right back up here. And then depending on how these work, it'll cause either an aquaporin channel to be opened or it's not usually there. Okay, but if ADH works, then it causes an aquaporin channel to open. I'll talk a little bit about that in a little bit. Okay, so that's reabsorption. Those are the things that we're reabsorbing. Anything else is just going on its merry way to be excreted. Okay. One last thing. There's also this thing called solvent drag. It happens as water moves between the cells and the proximal convoluted and PST, those two tubules. So as water moves, it's called paracellularly. If it's moving through the cell, it's transcellularly. Wow, that's hard. Anyways, as the water moves, it also drags calcium and potassium with it, and that puts it straight back into the blood. Okay, so that is solvent drag. Now we're going to talk about filtration. Again, I kind of like drawings, but I know some people really like writing as well. So I'm going to talk about this really quick. This is Bowman's capsule. Okay, we talked about it up there a little bit, but it's basically this cup or a sac that catches the filtrate, right? And the filtrate is coming from the glomerulus, which is right here. Okay, and these two together are known as the renal corpuscle. All right. Now, the afferent arterial brings blood into the glomerulus, and then efferent arterial is after the glomerulus. Okay. Now, what's being filtered is, it depends on the size and the charge. We have what's called fenestrae capillaries in there that are keeping really big cells from going through, and then we have a basement membrane in the capillary that is keeping things out based on their charge. And those are just kind of a couple of the basic things that go along that go into the makeup of the membrane. We also have podocytes, little protrusions here in the glomerulus, and mesangial cells that help keep these capillaries strong, because we're going to talk about hydrostatic pressure in a little bit. Anyways, as the filtrate comes out of the glomerulus, again, we talked about it like the proximal convoluted tubule, we have reabsorption, so things going back into the blood. We also have what's called secretion. We're pulling some stuff out of the blood so that it can be excreted down the road, which this is excretion. Okay. And like I said earlier, the peritubular capillary bed surrounds both the proximal and the distal tubules of the nephron. You can just ignore this. I'm not going to talk about juxtamedullary nephrons. What we're dealing with mostly, 90% of the time, is cortical nephrons. So I'm not going to jump into that. But I do want to talk about how blood flow can be regulated to the glomerulus, because this is really important, that the blood flow remains fairly constant. Because we have these pressures here, okay? Again, afferent arterial, efferent arterial. And then, so if you remember back a couple of videos when we were talking about the heart and blood movement and capillary movement, all that stuff, normally hydrostatic pressure was like in the 20s. But as you can see here, the hydrostatic pressure is 55. I guess it was a little higher than that. It was usually in the 40s. But anyways, it's quite a bit higher here in the glomerulus. Okay, and that's why those mesangial cells are so important, is they kind of help give some structure to them so they're not rupturing all the time. But that's also the reason it's so important for us to maintain blood flow to our glomerulus so that things don't get too crazy and we don't start breaking stuff. Okay, so this is our hydrostatic pressure in the glomerulus here. This is the oncotic pressure in the glomerulus here. So what's all these proteins and everything are drawing some water in. This hydrostatic pressure is pushing stuff out. And this is the hydrostatic pressure of the capillary. So it's pushing a little bit in. Okay, but I've got the math here. We got 55 minus 30 plus 15. So we've got 10 millimeters of hemoglobin of pressure pushing stuff out. And that's what's causing the filtration, is that hydrostatic pressure. Okay, and that, again, that needs to stay pretty consistent. So it's important that we regulate it, and that's called autoregulation. Now, if we have a high blood pressure, so a lot of blood is moving through there, what we're going to want to do is vasoconstrict, right? So that not too much blood is coming in here and we're going to start breaking stuff. That would be no good. Okay, so what happens is this afferent arteriole has stretch receptors. So when it feels a whole bunch of blood coming in, it starts to feel pushed. These calcium channels will open because they've been stretched. So the gate is now open, and so calcium will rush in, and it'll start constricting, so that not too much blood is rushing in here, gonna wreck stuff. Okay, so that's called the myogenic reflex. Now, we also have what's called the tubuloglomerular feedback. Okay, now if we have I'm going to back up really quick. So I talked about how the macula densa was important right there. It senses sodium chloride, right? So if the macula densa senses an increase in sodium chloride, then it's going to go here and it's going to cause an increase in adenosine, which is a constrictor in the kidney. That adenosine acts on the afferent arteriole, which causes the afferent arteriole to vasoconstrict. And when that vasoconstriction happens, that helps lower our blood pressure. So it kind of works in tandem with the myogenic reflex. Okay, it helps to lower our blood pressure, and that helps lower our GFR, the glomerular filtration rate, which we're going to talk about in a second. Now, if the macula densa senses a low sodium chloride, then it's going to release nitric oxide, which again acts on the afferent arteriole, causing vasodilation. Okay, when it vasodilates, we have an increase in blood pressure, which increases our GFR, which again, we have to keep that glomerular filtration rate pretty constant. So these are really important in making sure that we have a constant filtration rate, okay? Making sure that is staying the same. I just have some information here about the macula densa. I'm not really going to go into it. I can just talk about this really quick. My drawing up above is like unfolded. This is a little bit of a more accurate picture, super simple though. But this is called the juxtaglomerular apparatus, and it's where our macula densa right here is in close proximity to our afferent arteriole, right? And so that helps us release renin and can help us with our tubuloglomerular feedback. Okay, I'm going to move on now. We're going to talk about clearance. Okay, clearance is kind of difficult to understand. So I tried to just make it as clear as possible here that clearance is how much plasma is cleared of a substance over time. Usually that time is like a minute, right? They're looking at that, or it could be over an hour or something, right? There's ways that they can figure that out, and that's usually using this clearance equation. So this is clearance of some substance, and this U of X stands for the concentration of the substance in the urine. This V stands for the urine flow rate, and P of X is the concentration of the substance in plasma. So this is what people will use to figure out the clearance of an object, or of a substance, I'm sorry. Now the GFR is the glomerular filtration rate. So how much is being filtered per minute? GFR, normal GFR, is about 125 milliliters per minute. That's a pretty normal GFR. So these are related, and it's kind of hard to say how exactly they're related. I'm going to do my best though. So I've got this comparison of clearance to GFR. So if something has a clearance of 1, then that means there's no reabsorption or secretion of water or the solute. Okay, or the reabsorption and secretion of the solute and water have occurred at the same rate. They're happening at the same time. Okay, so either they haven't been reabsorbed or secreted, or reabsorption and secretion have happened at the same time. That means they're being filtered and reabsorbed at the same rate, or they're not even being filtered. So then there's no reabsorption or secretion, right? And that's compared to water. Okay, so same rate. That's the same GFR, and same, yeah, so clearance and the GFR is the filtration rate. So then if it's greater than 1, then that means this solute is being reabsorbed less than water, or the solution or the solute is also being secreted, which if we go back up here, it's being filtered and it's being secreted. So that means we're getting even more out of the plasma, right? It's being cleared out of the plasma. It's being cleared here and here. So that's pretty important to remember. So if it's greater than, it's being filtered, and it's not being reabsorbed hardly at all, if at all, and it's also being secreted. Okay, but now if it's less than 1, then reabsorption is happening at a greater rate than water. Okay, so here's a little chart that I've drawn out. So at 1, sodium is almost always the same as water, being filtered and reabsorbed at the same rate. Okay, now glucose, like I mentioned above, we should not be losing glucose. Glucose should be 100% reabsorbed. So that should be 0, right? And this could be like 4, I don't know. Okay, but the glucose should be 0, meaning it's being completely reabsorbed. Now, something that is being filtered but not secreted or reabsorbed, just plain filtered, is called, we've got inulin and creatinine. Inulin is a substance that has to be injected, whereas creatinine it's found naturally. It's just a normal byproduct of metabolism in our cells. So they can look at our creatinine levels in our blood and be able to determine if we have a normal GFR. So they're looking at our inulin levels, if they give us inulin, or our creatinine levels when they want to know if our kidneys are working correctly. I've got another drawing here. This shows the clearance of creatinine and inulin. They're happening again at a pretty constant rate. You know, as the plasma comes through, increases, so does the amount that's in our urine. Okay, glucose, nothing. But if we have a ton in our plasma, then we all of a sudden overcome all of these important SGLT2 transporters, right? That's and that's called saturation, right? When there's so much that we can no longer get everything through, so they start slipping by. This is our only glucose transporter. If we have too much and this glucose transporter can't bring it in and put it back into the blood, then it's going to go by and it's going to be peed out. So that's not good, right? We should have 100% reabsorption. If anything gets by, that means we have a problem. And that's, a telltale sign of diabetes is finding glucose in urine, because their blood glucose levels are so high that they're saturating these guys, so the kidney isn't reabsorbing all the glucose that it should be, because the levels are too high. So that's kind of what this is showing, is that change right there is when we're being saturated. So now we find glucose in our urine. Now this PAH, it's kind of a lookalike to penicillin. Now it is both filtered and secreted. So it's going to be greater than 1, right? It's filtered and it is secreted. So it's coming into the tubes in 2 different places, 2 different ways. Okay, and so that's why it's so much higher. Now it starts to kind of level off here, because again, it's saturated, so it can't just keep going on indefinitely. If we've got just so much PAH, then it's going to level off. Okay. Next, we're going to talk about the RAS system. Now, if we sense a low GFR, right, and low GFR, it's usually sensed by our macula densa, because if we have low blood pressure, there's a less amount of filtrate happening, so less sodium and less chloride. Macula densa senses that, and so it sends out a message for help, right? And that what it releases is this enzyme called renin. Renin reacts with angiotensinogen. That's another enzyme or angiotensinogen, and changes it into angiotensin 1. Okay, then ACE is another enzyme that changes angiotensin 1 into angiotensin 2. Now, angiotensin 2 does a whole bunch of stuff. It acts on the brain. It causes us to be thirsty, right? Because increased volume equals increased blood pressure, right? I kind of have that drawn over here. So angiotensin, everything that it does is trying to increase blood pressure. That's its job. So what it does is it causes us to be thirsty. So we're going to drink a bunch of water. That's going to increase our blood pressure. The brain also is going to release ADH, antidiuretic hormone. Okay. Also, if you remember from a heart section, we talked about baroreceptors. Baroreceptors are on the aorta, and they're on our carotid sinuses. Okay, when they sense low stretch, they release ADH. We also have these things called osmoreceptors in our brain, and they sense any slight change in osmolarity. So if they sense low sodium or low chloride or whatever, then they're also going to release ADH. Osmoreceptors are super, super sensitive. That's why I have it start here. Okay, and what ADH does, I'm gonna jump up here now. Actually, hold on. Let me get through all of this, and then I can talk about ADH and aldosterone together. So, the brain releases ADH, baroreceptors release ADH, and osmoreceptors, well, these cause a release of ADH. The brain actually sends it. Angiotensin 2 is also a vasoconstrictor, right? It's just going to do systemic vasoconstriction, which also increases our blood pressure. Okay? Angiotensin 2 also acts on the kidney, and it constricts specifically the efferent arteriole. So if I've got an artery here, yeah, I'm trying to think how to explain this really quick. If this is my glomerulus here, and I all of a sudden constrict this to this, we're going to have a buildup back into here, right? So we had a drop in pressure, but then I constricted all of this, so now I've raised the pressure in here, right? And this is to help keep GFR constant. Okay, so that's what that's doing when it's affecting the efferent arteriole. It's on the back side. The afferent is coming from this side. If I constrict this side, then I'm going to be decreasing GFR because not very much blood is coming through. So that's going to help us decrease GFR if if our blood pressure is high. Okay. Angiotensin 2 also works on the adrenal gland and releases aldosterone. Okay, now aldosterone affects our sodium potassium ATPase pump, which increases our sodium reabsorption and potassium secretion, right? And so I'm going to go up now. I'm going to talk about aldosterone and ADH, since I have them drawn here. Okay, so like I said, aldosterone works on the sodium potassium ATPase pump. So it starts pumping this out even faster, right? So now we're reabsorbing sodium a ton, and we're secreting potassium even more than we were. Okay, and so because that's happening, this ENaC channel is working overtime. So we're pulling even more sodium from the lumen. Okay, now at the same time, if we have ADH that's released into the system, it's going to act on this G protein here. This alpha subunit is going to come to this vesicle here that has a bunch of aquaporins. When this alpha subunit comes here, it activates this, and it's going to put an aquaporin here on the membrane. Okay, and then that allows water to come through and be put back into the blood. That also is going to help increase our blood pressure, right? Because we're putting more water in. More water, more volume, more blood pressure, higher blood pressure. Okay, so if we're dehydrated, we're going to be pulling as much water as we possibly can, right? Again, we're thirsty, so ADH is going to be working a ton, so we're going to be pulling it out. If we're overhydrated, we're not going to be doing this, right? We don't need to be reabsorbing. So that's why when you're dehydrated, the color of your urine and its concentration is so high, and the color is like super yellow, sometimes even brown if it's like terrible, right? Whereas when you're really well hydrated, it's clear. Sometimes it's even the color of water, right? And that's because we're not absorbing water, so water is just able to leave. Okay, so that's the RAS system, and how ADH and aldosterone work. The last thing I want to talk about is how the loop of Henle is used to establish and maintain the concentration gradient. So I'm going to jump back up here. Okay, so this is the loop of Henle right here, okay? Like I mentioned before, in the descending loop of Henle, we have only aquaporins. So water's coming out here, right? But then we come up here and only ions are leaving. Okay? So if we have a whole bunch of ions being put out over here, and it goes into the blood, right? And then the blood moves this direction, we have a high concentration of solutes out here. And we've learned in previous lessons that water follows dots, right? And so that's what causes all of this water to come out. Okay? So this is called a countercurrent multiplier. As we increase the amount of solutes here and it moves this direction, as this all moves this way, then we're able to get more water out here. Because if we weren't allowing for solutes to leave up here, then water wouldn't really leave here. It'd just stay the same. So this countercurrent multiplier is really important to help establish and maintain concentration gradients. So the loop, that's what loop of Henle's job is to establish that. This causes this, and that's the concentration gradient that we need. Yeah, and I already talked about how ADH works to excrete urine of different concentrations, right? If we're dehydrated, that means we're pulling more and more water out and putting it back into the blood. And so then we're only left with filtrate, right? So it's really concentrated as we urinate. Whereas if we're really highly hydrated, then we don't need to pull water out. So we just let it all go, and so it's very clear, very not concentrated. So that's it for the kidney. Thanks so much for watching. I hope you enjoyed and learned something.